Hi, this is County Judge Samaniego. The 2020 census count is incredibly important for El Paso. It helps our school, healthcare, food and housing programs get the money they need.
This is County Commissioner Vince Bettis for Precinct 3. With your participation, the programs that support affordable housing, public education, and affordable health care can receive the funding they deserve.
This is Commissioner Carl L. Robinson, Precinct 4. Without you, these programs could not be successful.
This is Commissioner David Stout. Participate online, by phone, or by mail. Everyone in El Paso County must be counted, even children and babies. Your responses are safe and required by law to be kept confidential.
Hi, this is Commissioner Carlos Leon from Precinct 1. Let's come together and fill out those 2020 census. Together and fearless, we count.
The County of El Paso Public Works Department is offering sandbags at no cost or requirements to the public. The sandbags are outside of the facilities and are available 24 hours a day. The location of the county facilities are the following: the Road and Bridge Fabens Warehouse, located at 1331 North Fabens Street in Fabens, Texas, 79838. The Road and Bridge Canutillo Warehouse, located at 191 Canutillo Avenue in Canutillo, Texas, 79835. And the Road and Bridge Montana Warehouse, located at 14698 Van Lane, El Paso, Texas, 79938. Don't wait in line, pay online. Visit the Financial Recovery Division website at http://www.epcounty.com/budget/financialrecovery.htm to make your payments online or find out more about our kiosk locations. We now accept payments on misdemeanor, felony, and justice of the peace cases.
You can now watch Commissioners Court meetings on YouTube. Go to youtube.com and search for El Paso County Commissioners or El Paso County, Texas. Subscribe to our channels to see our latest videos. Did you know the County of El Paso's Purchasing Department is responsible for ensuring that all items and services needed by various county departments are purchased in the manner required by the state of Texas? Whether through formal sealed bids or smaller dollar quotations, the county purchasing team is dedicated to finding the best contracting return on your taxpayer dollars. Additionally, the Purchasing Department is responsible for the tracking of inventory within the county and properly disposing surplus through public auctions. For questions about how to become a vendor and compete for county contracts, or to learn more about public auctions, please contact us at telephone number 915-546-2048.
The 346th District Court Judge Angie Juarez Barril started the El Paso Veterans Treatment Court program in 2012 for veterans and active service members that have been arrested and charged with a felony or misdemeanor criminal offense. To be considered for the specialty court, the statutory criteria includes be a veteran or current member of the United States Armed Forces, including a member of the Reserves, National Guard, or State Guard, and suffer from a brain injury, mental illness, or mental disorder, including PTSD, or be a victim of military sexual trauma, all occurring or resulting from military service. Call Sylvia Serna, Veterans Program Director, at 915-546-2119, or email her at sserna@epcounty.com for any information.
Did you know that the County of El Paso's fixed asset control and inventory disposal is handled through the Purchasing Department? Throughout the course of each business year, the county holds live public auctions to dispose of aged equipment, vehicles, furniture, and other items that are no longer needed. To find out about upcoming auctions or to learn more about the county's inventory disposal process, contact the purchasing department at telephone number 915-546-2048.
Cesar, we are up.
Good morning, ladies and gentlemen. Today is Wednesday, May 20th, 2020. Commissioners Court is meeting in special open session. Today, we're joined by ASL interpreters Maria Hernandez, and Dario Garcia. Would you please rise and join us for the Pledge of Allegiance?
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Item number 3 is public comment. At this time, we do not have anyone signed up for public comment. Item number 4, discuss and participate in a presentation from Congresswoman Veronica Escobar's office regarding community response to COVID-19.
This is Miguel. I've already dialed into the Zoom. I'm just have a screen that says, please wait, the webinar will begin soon.
Thank you. Miguel, we have everyone, all the commissioners are on the call,
Everybody's here. And Commissioner
Excellent.
Robinson as well.
Well, good morning to everybody.
We'll put up his picture if he talks.
Good morning.
We're going to isolate just the commissioner's video signal to Congresswoman Escobar.
Miguel, my understanding is that we're not going to be able to interact unless there's a question, but it's more of they have quite a panel there, and so we'll be listening into the most important thing, it's being broadcasted, and so a lot of other individuals get to see the presentation because it will be in open meetings.
Yes, your microphone is on, and you'll be able to listen to everything. So, unless you mute yourself, then you're muted.
participar en español también oprima interpretation en la parte baja de su pantalla. Good morning, my name is Eduardo Lerma. I will be moderating today's discussion with the Congresswoman Veronica Escobar's office. I am her chief of staff. Thank you for joining our live conversation today. We will be having a great conversation on the increased vulnerabilities of COVID-19 in the El Paso del Norte region. Congresswoman Escobar is joined today by Dr. Scott Gottlieb and Dr. James Hildreth, two nationally recognized public experts in their field. Congresswoman Escobar, the floor is yours, ma'am.
Thank you so much, Eduardo. And I want to thank everyone who is participating in this Zoom conference for being here. We know your time is precious, especially during this crisis. I want to thank everybody watching on Facebook as well. We have an incredible event for our community that's about to begin. And I first want to announce that we have elected leaders from the local, state, and federal level and the local private sector on our call today from our tri-state region, from El Paso, Texas, from Ciudad Juarez, Chihuahua, and from Doñana County, New Mexico. And so my many thanks to all of you, our community leaders in the region who have done so much to keep our residents safe. I want to begin by just offering a little bit of context before we hear from our incredible speakers. First, let me describe the situation in El Paso for context. We have a population in El Paso County of about 840,000 people. 83% of our residents are Latino, 4% of our residents are African American. So that means almost 90% of our community is made up of minority residents. A quarter of our community is made up of immigrants. We face some pretty significant challenges with our poverty rate. 20% of our community is at or below the poverty rate. Now, when it comes to what's happening with regard to COVID, we've had almost 1,900 positive cases. We've seen 52 of our residents die as a result of this pandemic. 2.5% of our population has been tested. And as we know, the state of Texas is well underway to being open. El Paso has been granted a 1-week reprieve on the second phase of the reopening of Texas. So not this Friday, but the following Friday, we're going to begin to see bars and other places where people congregate begin to open. Now let's look at our neighbor to the north, Doñana County, New Mexico, a population much smaller than ours of about 218,000 people, but they too are a majority minority community. Their population is 68% Latino, 2% African American. So 70% of their population is made up of minority residents. Their poverty level is higher. They're at 27% poverty rate, but nearly 5% of their population has been tested. So their testing has been twice as much as ours in terms of a percentage. They've had 319 positive cases and 2 deaths. Now let's look at our neighbor to the south, Ciudad Juarez, Chihuahua. Much larger metropolitan area, population of 1.5 million people. There is unfortunately more mystery about their testing, and it was very difficult for us to get information about their testing. We know in Ciudad Juarez, there have been 640 positive cases reported, 158 fatalities. But here's what we have learned in the last 48 hours. We've learned through Senator Udall's office that as a public policy, the government of Mexico has decided that it will only offer public testing for people who've been admitted into the hospital. So that's a very different strategy, obviously. And so as a result, they have very limited testing. As of May 11th, only a total of 156,000 people have been tested in a country of 126 million people. Oh, sorry, hang on one second.
For our attendees today, if you'd like to ask a question, please click on the bottom of the screen where it says Q&A, and you will be able to write your full name and question, and I will call on you as the time allots.
Thank you so much, Eduardo. Sorry, our speaker is picking it up for some reason, modern technology. So the context that I provided for you is to demonstrate that essentially we face a kind of a double whammy as a region. Last week, or the last couple of weeks, I've had conversations with Dr. Anthony Fauci, who is part of the president's task force, COVID-19 task force. And he expressed that communities like ours, which have a minority population, that we are as vulnerable as communities that are, we are as vulnerable as people in nursing homes and in assisted living facilities. You add to that the fact that we are across from a country that has not prioritized testing in the same way, and we face a real challenge. We are all eager to get out and to get as back to normal as possible, to reopen the economy and to get things moving. The question is, what's the best way to do it? What should we be thinking about? Not just in terms of this crisis, but in terms of prevention. We are very fortunate to have two incredible leaders with us who are generously sharing their time and their expertise with El Paso and our region. We're going to hear from both of them and then take as many questions from you as possible. We will first hear from Dr. James Hildreth. I actually became introduced to Dr. Hildreth when he testified before the Congressional Progressive Caucus on COVID-19 and the disparities that exist for minority communities like ours. And his testimony was really powerful. He is a world-renowned HIV researcher. He and Meharry Medical College are playing a vital role in the national fight against COVID-19. You've probably seen him all over television as he shares his expertise with all of us. Dr. Hildreth, I'll turn it over to you.
Thank you. Representative Escobar, thank you for having me. I'm pleased to be here to share some thoughts with you and the listeners today, those who are viewing this. Let me start by trying to put this all into context. COVID-19 disease is caused by a virus called SARS-CoV-2, and it's a member of a family of viruses. There are 7 members in the family. These are coronaviruses, some of which have been around since the 1960s. But unlike those viruses, the virus that causes COVID-2, that causes COVID-19, is entirely new to the human population. And what that means is that there is no pre-existing immunity to this virus, and that is why it is marching through the human population around the globe and infecting millions of people. The other thing that you need to know about the virus is that viruses go into cells by way of proteins called receptors. And depending on where the receptor is, that's where the virus will infect our bodies. Example is hepatitis. Hepatitis is caused by a virus that infects the liver. And that is why the liver gets damaged and we get the disease hepatitis from that virus. The receptor for the COVID-19 virus is in lots of places in our bodies. It's in our GI tract, it's in our lungs, it's in our testes, it's in the kidneys. It's in a great many places, and that is why the virus is causing such a broad spectrum of diseases. People are getting blood clots and having strokes. Of course, we all know about the severe lung disease that happens. There's a loss of smell and taste. There can be GI symptoms that are seen, and that's new to have a virus that causes such a broad range of symptoms in people. There is no treatment for this virus, and there is no vaccine. So the only thing we have to protect ourselves, and I'm sure Dr. Gottlieb is going to talk about this, is mitigation steps like social distancing, wearing face coverings, and things like that. What I'd like to mention, though, is another profoundly important part about viruses is if our immune system is compromised, or if the organ that is the target of the virus is compromised, you get much more severe disease. And what do I mean by that? So in China, where the virus first took hold, and keep in mind that China is a very racially homogeneous nation. If you had hypertension, high blood pressure, diabetes, heart disease, or you smoked, you're much more likely to get severe disease and die. So even in a racially homogeneous nation, we observed that underlying conditions would cause you to get more sick from COVID-19 and possibly die. Here in the United States, we've known for at least a couple of decades that if you belong to a minority population, you're much more likely to have those things, to have hypertension or cardiovascular disease, to smoke, to have asthma, to be obese. And that is why in the minority communities around the country, African Americans, Latinos, and others, minority groups, are being devastated by this virus. You've probably read and heard that even though African Americans, for example, are only 13% of the population, 60% of the people who are dying are African American. And that's really, it's an unacceptable statistic, but it's what we have to deal with. And to be reminded there's another pandemic happening in the United States, that's HIV and AIDS. And the story is very similar, that even though we're only 13% of the population, 43% of the cases of HIV and AIDS happen in African Americans. And if you happen to be a young African American or Hispanic male, and you happen to be gay, your lifetime risk of getting HIV is 1 in 2, 50%. So these are like devastating statistics that relate to the fact that minority communities have many, many structural challenges to being healthy. They include poor access to healthcare is one of those. Not having access to a quality diet. Many of us live in food deserts. We cannot afford to get our hands on healthy foods. There's not an ability to separate ourselves, to be socially distant. We know that density is a factor that drives the spread of the virus. And that is why densely populated urban centers in the United States have been besieged by the virus. And often in minority communities, we live in multi-generational families where there are lots of individuals in a single household, and you can have 3 or 4 generations living together. And if you're a young person, you go out and you get the virus and bring it home to your extended family, that can be devastating because we know that older individuals, many of them have chronic conditions. They're much more likely to get severe disease and to die. So one of our challenges is finding a way to protect vulnerable populations. As Representative Escobar said, in the United States of America, there are several vulnerable populations. They include people living in assisted living facilities and nursing homes, people in prisons, and also minority communities, because we happen to have a much higher burden of those diseases that cause COVID-19 to be more severe, but also the social constructs that we live under make it possible for the virus to spread much more rapidly in our communities than in other communities. And I've spoken about the density, but we also work in jobs that force us to be close to each other and to be exposed to people in the community, in grocery stores, in meatpacking plants, in factories. We have jobs that tend to make us more vulnerable to disease than other people might be. And one of the aspects of this, as I mentioned earlier, that I'd like to emphasize, high density populations are more prone for rapid spread of the virus because we are the vectors. Human beings are the vector that spread the virus, unlike the previous pandemics where you had to come into contact with animals, cats or camels. We are the vector for the virus, so anytime you have crowded conditions, be it a cruise ship, nursing home, prison, housing facility, all those things make it more likely that the virus is going to spread. And I want to emphasize that absent a vaccine or a drug to treat the virus, it means that those populations are much more prone to much more severe disease and to dying. And that is why I believe that, and I've said this to members of Congress, to members of the Senate, to people in the White House, there needs to be a preemptive strategy to protect those vulnerable populations. I'm talking about minority communities, nursing homes, prisons. We know that if we do that, we can save many, many lives. And it bothers me a great deal that we've not found the wherewithal as a nation to do that, because it needs to be done. The other thing let me say is that we as individuals have some degree of power or ability to protect ourselves by washing our hands frequently during the day, wearing face coverings, social distancing, and those sort of things. But having said that, I'm acknowledging that some of us do not have the ability to do those things because of the living conditions that we're under. And to me, that needs to be addressed as well. There need to be resources made available to empower all of us to do those things that keep us safe. But I'm particularly concerned about the multi-generational households where younger people might not be aware of the fact that they're bringing the virus home to the people they care about. And that's a major, major concern in areas like El Paso and Juarez, where those conditions are rife in our communities. So the bottom line is that the virus is out there. It's going to be with us for a while until we have a drug or a vaccine. But in the meantime, we have to find a way to protect vulnerable populations, and certainly the communities that we're all familiar with fit that category. And we have to find ways to protect them. So thank you.
Thank you, Dr. Hildreth. Eduardo?
For those attendees today, if you have any questions, please click the Q&A button at the bottom of the Zoom page, and you will put your full name and question, and I will call on you after introductions. Thank you.
Thank you, Eduardo. And thank you so much, Dr. Hildreth. And I think one of the things we're going to want to explore is, how do we do this? How are we going to protect the vulnerable communities? What percentage should we be testing at? We've seen New Mexico, our neighbor, Diana County, a much poorer community, testing at twice our rate. What is the appropriate rate? And I'm sure our folks have questions like that. Our next guest, you have probably also seen on television and have read his pieces in the Wall Street Journal and other publications. He is Dr. Scott Gottlieb. We are so fortunate to have him with us as well. Dr. Gottlieb served as the 23rd Commissioner of the Food and Drug Administration. He's currently a resident fellow at the American Enterprise Institute, AEI, where he continues his work on improving public health through entrepreneurship and medical innovation, and on expanding regulatory approaches to maintain patient and physician autonomy. His most recent Wall Street Journal piece we shared with all of you. Hope you had a chance to read it. Dr. Gottlieb, thank you so much. The floor is yours.
Thanks for having me. It's a real honor to be here today, and thanks for letting me share some thoughts. I thought what I would do is just give a little bit of a sense of what I perceive the outlook to be as we head into the summer and then head into the fall. Some of the challenges we'll face with this virus and what we can do to mitigate it. And I'm going to pick up on the previous speaker's thoughts and comments, which I think were right on the mark. Right now, we're starting to see the country reopen. Nationally, if you look at the trends nationally, we're seeing cases come down. We're seeing hospitalization rates come down. We still have a high level of infection overall, a persistently high level of infection. I think many of us who were proponents of the mitigation steps that we took as a way to prevent more tragic deaths and to prevent the healthcare system from becoming overwhelmed, estimated that we'd be at a lower level of spread right now, that the mitigation would work to flatten the curve and prevent the healthcare system from getting overwhelmed, but it would also work to lead to more sustained declines in new cases. And you're seeing that in certain parts of the country, but you're not seeing that nationally. There's been persistently high infection. We still are averaging over the last week around 1,200 tragic deaths a day. About 25,000 infections are being diagnosed. Now that's against a backdrop where testing is going up. So positivity rates, meaning how many people we're finding are positive as a percent of the total that are being tested, are coming down. But there's still a lot of infection in the community. Hopefully that's going to continue to trend down. I do believe there's going to be a seasonal effect here. And as we head into the summer, that's going to have an impact on viral transmission. People are outside more. Respiratory pathogens typically don't transfer as efficiently in hot, humid weather. That's why we don't see typically coronaviruses be summer pathogens. Typically they're in the fall and winter. Same thing with influenza. So hopefully there is a seasonal effect here, and this transmission will start to slow down nationally, even against the backdrop of where we're reopening and relaxing some of the social distancing, which is going to be something that ends up increasing spread. But hopefully as we get into July and August, things will start to break off a little bit. And that's in fact what we saw in 2009 with H1N1, the novel flu that became pandemic that season. We saw that flu really have epidemic spread all the way into June. And then in July and August, we saw it really start to regress. But what happened in 2009 was when we came back in September and schools were back in session, residential colleges were back in session, and people were back at work and indoors more, we saw that start to pick up. And it started to spread again at epidemic levels. Now, in that year, we had a vaccine available in September. We had 4 more vaccines available in October when we started mass inoculating the population before December of that year. So we had a vaccine. We might not get so lucky this time. I think we're going to have therapeutics that are going to be effective against coronavirus, and I think eventually we will have a vaccine. But it's going to be challenging to get a vaccine available in time for the fall that can be given widely to the population. I think a vaccine here is really probably a 2021 event. And so heading into the fall, assuming my optimistic scenario comes to pass and we can all relax a little bit and take a little bit of a breather this summer and start to get back to some semblance of normal lives when transmission does start to break off, hopefully in July and August. Not completely, we're still gonna have spread, but hopefully it's reduced. When we come back into September and October and face that renewed risk of increased spread, there's things we're going to have to do differently to prevent additional outbreaks and to prevent another epidemic. It's going to be really important at that point that we have in place very good screening, very good capacity to do testing, that we're testing not just people who are symptomatic, but also people who are asymptomatic, that we're offering it very routinely and trying to do some surveillance testing. And to the prior speaker's point, it's very important that we target those resources into at-risk environments. Not everyone is equally at risk of coronavirus. There are communities, there are people who work in certain settings, there are people who live in certain settings who are at higher risk of this virus than others. And it's very important that we make sure the resources and the testing is getting into those at-risk environments, that we target them effectively, because certain communities, certain settings, certain professions end up being where the virus goes first and where it becomes where you get a lot of people getting infected and infected by the virus, and where it then becomes a source of spread. And that's why you're seeing the outbreaks in the meat processing plants, grocery stores. These are environments where people can't naturally social distance at work. They're close together. We're not getting proper protective equipment into all of those settings, and so people aren't able to protect themselves. And some of these are professions where you come into contact with a lot of people. So think of someone who works in a grocery store in the checkout line. They're coming into contact with many people over the course of a day. They can't naturally social distance. That's putting them at increased risk. So it's important we get testing into those sites and also into places of employment. The other thing that's going to be very important for the fall is to rely on what we call case-based interventions. So right now we're relying on what we call population-based mitigation. We're effectively isolating entire populations and asking people to stay at home to prevent the virus from spreading. What we want to get to is a point where we can catch up, where we can keep up with the virus, and instead of targeting the whole population with mitigation, we try to target people who are either at risk or people who are infected, get them tested, ask people to self-isolate, try to track who they've been in touch with and offer those individuals testing to try to look at the individual cases of infection and target those cases. And also make sure that getting COVID and being COVID positive and identifying yourself as someone who's positive or seeking testing isn't something that becomes punitive, that people are encouraged to get tested, they're encouraged to self-identify, and it's not something where you're forced into isolation and you're forced to lose wages and you lose your job or you're not able to work. We need to find a way to make sure that this isn't punitive so that we can inspire the community to go out and self-identify if they have symptoms of COVID and go out and get tested. That's going to be very important heading into the fall. So these sort of case-based interventions, trying to keep up with the infection, get people screened, have people who are positive self-identify and self-isolate, going to be very important to trying to prevent this from becoming epidemic again and prevent outbreaks from happening in the fall. I do believe we're going to have more therapeutics. We're going to have a much different toolbox in the fall. I think we will probably have vaccines available at the very least on an experimental basis that we can deploy in large clinical trials, both to test whether they're safe and effective and make that determination, as well as potentially deploy them in the setting of outbreaks to try to ring fence those outbreaks in cities. And so we're going to have those tools available. I think we're also going to have much broader screening available. The capacity to do testing is going to ramp very quickly. And so there's going to be a lot of platforms that are available to test people. I think the challenge is going to be getting people tested. So there'll be plenty of platforms where you can run the tests. The question is, where will people be able to go to get tested? Will you be able to go to your doctor's office and get tested? Will you be able to go to the pharmacy and get tested? Will there be special sites to offer testing? Will it be available at the workplace, especially in workplaces where people are at risk of contracting the infection? You know, to give you an example, if we have public health regulations that say that if a doctor has a COVID positive patient in their office, that they have to close their office and do a deep cleaning and quarantine their staff, doctors, providers aren't going to test for COVID in their offices. They're going to refer people to COVID testing sites, and that's going to limit people's access to testing. So we need to make sure that we put in place public health regulations and measures that makes testing ubiquitous in the community, makes it widespread in the community so people can easily access the opportunity to get testing, both in healthcare settings as well as at places of employment. If we can do those things, I think that we face a much different environment in the fall, and we can reduce this risk. But I don't think this risk is going away. I think COVID's going to be with us probably perhaps forever. I mean, this could become what we call an endemic illness, where this just is one of the circulating strains of coronavirus that comes around every year. But it becomes something that's a much more manageable threat with a vaccine, with effective drugs, with good public health measures in place. This might become something like the flu, where we just get vaccinated for this every year. And you know, it still is a threat, but it's a much more manageable threat. And so that's the future I hope for, you know, but we need to do the right things heading into the fall. And I want to thank the Congresswoman for having me here today. And I look forward to working with her and many others on achieving these goals. Thanks a lot.
Thank you so much, Dr. Gottlieb. Eduardo, I'm going to turn it over to you to begin to field questions for our experts. We're going to take 2 questions at a time and then let our experts respond, then take another 2, etc. Eduardo.
Thank you, Congresswoman. And our first 2 questions will be from State Representative Cesar Blanco and State Representative Mary Gonzalez. Representative Blanco, you are unmuted. What is your question?
Thank you, Congresswoman. Can you all hear me?
Yes.
Yes.
Okay, well, thank you, Congresswoman and Drs. Gottlieb and Hildreth. My question is related to our border region. As you all know, El Paso is part of a multi-regional area. And we're geographically uniquely situated, unlike any other county in Texas. We've got the state of New Mexico and the country of Mexico that we share a border with. We know that the US, Mexico, and Canada have agreed to extend border travel to essential travel only. And we're really the largest international metroplex in the world. And I think that we have an opportunity to lead in COVID-19 response from a perspective of binational, multi-jurisdictional response. So my question is, are we seeing any testing coordination, any contact tracing coordination in other countries? And is a role that the World Health Organization can help give guidance to international border communities?
Thank you, Representative Blanco. Representative Mary Gonzalez, you are live now for your question. You might want to hit unmute. Representative Gonzalez? Okay. Well, Congresswoman, I think if we
so let's answer Representative Blanco's question, and it really gets to the heart of the unique situation that we are experiencing in El Paso, both with the vulnerabilities, Dr. Hildreth, that you've outlined, and our location on an international border where it is still somewhat fluid, something that is a point of pride for us, but also can present a challenge during times like this. What do you all, in response to Representative Blanco's questions, your thoughts?
Well,
I would defer to Dr. Hildreth. Yeah, thanks.
Well, I was going to defer to Dr. Gottlieb, but I do have a thought about this, and one is that pandemics are global epidemics, and it requires, if it's going to be dealt with effectively, for countries to cooperate with each other. I mean, clearly, in Europe and other places, you see examples of where failure to cooperate or to coordinate efforts between countries can lead to, I mean, really major outbreaks and excess death, in my opinion. And here's an example of that. I think that just throws into high relief how important it is for global leaders to interact and cooperate with each other. I've said to folks that I wish that the way that scientists around the globe have come together to collaborate could be emulated by our national leaders, because if that were the case, we could put this behind us a lot sooner. I mean, I don't, that's my observation is I agree with you that it's important for that to happen. But unfortunately, in the political context that we're in right now, that would be very challenging. But I think that whenever you have a pandemic, by definition, it'll be much more effectively dealt with if global leaders were cooperating with each other rather than pointing fingers.
I'll just build on that by saying I think that this caught the world unprepared in this first instance, and I think people didn't fully anticipate all around the world how this was going to spread around the world and how quickly it was going to spread around the world. Maybe some in the science community did, but I don't know that everyone in the policy community did globally. This wasn't just in the United States, but really globally. I mean, Europe ended up being very vulnerable and not anticipating the flow risks. I would hope that heading into the fall, now that we understand how contagious this pathogen is, how deadly it is, how impactful it is, both from a public health standpoint as well as the economic impact, that we take more measures to try to implement more cooperation globally to do things to try to contain spread and do effective surveillance. Because the reality is, if this does become a seasonal pathogen, we are very likely facing this situation where this is probably going to become epidemic in the Southern Hemisphere as they head into their winter and we head into our summer. And that's going to be a very big reservoir and pool of potential spread heading into our winter. And so we're going to need to be working with those nations to try to control spread there and try to help support them, as well as make sure that it doesn't get transported back into the US and become epidemic here again.
Thank you so much. Eduardo,
Thank you.
Who's next?
Representative Mary Gonzalez, try you one more time. You are unmuted.
Okay, sorry about that. Thank you, Congresswoman, for hosting this. I think it's critically important. One of the things I feel is a disconnect, and I even see it on my own Facebook page, is I'll post notice about testing that we're doing through the Texas military offices, and then I'll get responses like, from people like, you don't need to get tested if you don't show symptoms. And I'm like, no, everybody needs to get tested. And I think there's this disconnect because for so long we had told people you can only get tested if you show symptoms. And now we're trying to say, I feel we're trying to change that message, and that message is maybe struggling to get heard. Can our experts talk about testing even if without symptoms and the importance of that, and maybe some ways we as a community could try to change the messaging that was given previously?
Yeah, I'll pick up on that. Yesterday, Maryland announced that they're going to open testing sites and make it available for both symptomatic and asymptomatic individuals, that people can get appointment list tests at multiple sites they're setting up, and whether they have symptoms or they don't have symptoms. I think it's going to be very important that we make available testing to anyone who wants it. People who might be worried they were in contact with someone who is sick and but they're asymptomatic. People who might have signs or symptoms that aren't even suggestive of COVID, but they have personal concerns that they could have been exposed to it. I think we need to implement more routine testing for people who are in at-risk environments if we're going to control the spread heading into the fall. There's been, so far to date, there was limits on who can get tested, in part because there was limits on the testing capacity. So there was a backlog of tests around the hospitals. And so there a lot of the testing capacity was being apportioned to hospitals and only to people who showed signs and symptoms of COVID, even in the community as testing expanded into the community. I think testing capacity is going to be less of an issue going forward. It's certainly an issue right now. So I'm not trying to say it's off the table, but you're going to see a number of products get approved or authorized by the FDA in the coming months. And I don't know anything special. This is just what's in development that I would anticipate that's going to open up many more point of care testing systems that are going to be available in doctors' offices, what we call antigen-based tests, which are very inexpensive, easy tests that you can do right in a doctor's office and get an answer right there, like we have for this flu and for strep throat, where it's literally like a swabbable stick. You're going to see next generation sequencing used to do large testing of pooled samples. So you can test multiple people at the same time in places like big workplaces where you want to test 100 employees or 1,000 employees. You'll use pooled samples rather than testing each person individually. And we're going to see a continued buildup of the platforms we're relying on right now, which are primarily PCR-based platforms that look for and try to detect the nucleic acids, the DNA, if you will, of the virus. That's how they test for the virus right now, predominantly. So we're going to see all these platforms come into the market. And the challenge is going to be the testing sites, the front end, not the back end. The back end has been the challenge right now, not having enough tests to run to run these samples on. The challenge in the fall is going to be the front end. Where do you go to get tested? And are there a lot of sites, and are they easily accessible? And are they in the communities where we need to get the testing most of all? And I think that's the challenge we need to focus on heading into the fall, because the back end challenge, which we've had to date, and it's the challenge that speaks to the issue that you're talking about, that's going to get resolved, I think, by innovation that's going to enter the market. And it's going to be the front end thing that we're talking about.
So from my perspective, it's really important to do testing on a larger scale, because there's so many people who are pre-symptomatic or asymptomatic who can transmit the virus. We can't identify those persons unless we do testing of those who are asymptomatic or pre-symptomatic. And you can't find those individuals if you're only testing those who are symptomatic. And of course, if you only test the symptomatic folks, the percent positive tests is really high, but that reflects the fact that you're testing people who are probably positive just from their symptoms. So I think it's going to be very important in minority communities, especially, to do widespread testing to identify the positives, do contact tracing, isolation, and treatment. And that's how we keep those populations protected. I'm really happy that here in Tennessee, the governor made two very important decisions that I'm really applauding him for. He's made testing available to anybody in the state who wants it. And he's also testing every nursing home and every prison in the state to find those who are positive. And that's going to be followed up with contact tracing and isolation. So as far as I'm concerned, testing is at the heart of protecting vulnerable populations, and it needs to be implemented as soon as possible on a wide scale.
Thank you so much. Eduardo.
Thank you, Congresswoman. We have El Paso County Commissioners Court live as well. Judge Samaniego, I'll recognize you.
Thank you. And Congresswoman, always a privilege to have someone that had been so successful as a county judge and now be at the level of Congress and really understanding the makings and the dynamics of our community. And I think we're having a difficult time trying to express to the rest, to individuals that don't live here in El Paso, the incredible symbiotic relationship that we have with Juarez and Doña Ana. My question is more that there seems to be in Texas the idea that we need to learn to coexist with the virus. And I feel that that strategy might be good, maybe as we look back and we understand what happened and we understand all the moving parts. But there is a real push for, we used to be very successful when public health was leading the charge, and then we try to minimize the impact on our economy. It seems now that we're trying our best to say, let's open the economy and let's mitigate how we handle the virus. And so I like the incredible experts that we have on the panel. It's just so, we're so privileged in El Paso to have that opportunity. But how do you see this idea where we feel that the economy is getting ahead of public health and the balance seems to be shifting towards more the economy and public health trying to do something about the impact it'll have on the virus?
Well, I mean, I'll just comment briefly. It's hard for me to comment specifically on Texas. I'm not that familiar with some of the local policy decisions that have been made in each individual state. I'm working very closely with Maryland and Massachusetts, my governor here in Connecticut and New Jersey. So I'm more familiar with the states that I've been working with. I think that the challenge here for public health officials is that there's costs on both sides of this equation. I mean, there's a public health implication from the economic impact, first of all, but there's also a public health cost of the mitigation. If you look at vaccination prescriptions are down by 90%. Those are people who missed flu vaccines and measles vaccines, some of whom never going to get vaccinated now. And we're going to have outbreaks of those illnesses heading into the fall because of declining vaccination rates. You look at data on chemotherapy follow-up visits were down 20%. People missed chemotherapy visits. People missed routine cancer screening. So there's going to be public health implications for the mitigation steps that we took. Now, that said, we had to do what we did because the reality is there was no public health so long as our hospitals were going to be overrun with coronavirus. The virus literally shut down the healthcare system in New York City. There was no public health. You couldn't get healthcare in New York City. The hospitals were overwhelmed by COVID, and that was in multiple cities. New Orleans, Chicago, Detroit faced similar circumstances, not quite on the same scale as New York, but on a similar scale. And so if this virus had spread around the country in a similar fashion and the healthcare systems were overrun, there wasn't going to be any public health. But we need to recognize that by continuing the mitigation steps, there's continued implications for the long-term public health. And so the question is, when do you start to lift them? I think, I put forward a plan, others have, in terms of when you can slowly start to reopen the economy. I think there's prudent ways to do it. You do it in a staged fashion. You do it after you see sustained reductions in new cases and hospitalizations. You do it when you have in place the tools to manage illness, the screening capacity, the ability to do track and trace. So there's, I think, identifiable benchmarks that could put a state in a better position to reopen an economy against a backdrop where there still is going to be virus, but it becomes a manageable level of virus, and it becomes something that we can continue to reduce the levels of the virus. It's hard for me to judge whether Texas is there or not. I'm not as familiar with the local situation, but the truth of the matter is, I don't know that we're ever going to fully eliminate COVID until we can vanquish it with a vaccine. I think there's always going to be some level of spread. And we're going to need to learn to contain it, to isolate it, to identify it, to target resources to people who are most vulnerable from it. But we're always going to have to deal with it in some fashion. It's a virus that is highly contagious, and by its simple, virology, wants to infect between 50 and 70% of the population. That's the rate at which it wants to spread. That's its attack rate, and so we're going to need to continue to take steps to keep it from spreading the way the virus would unchecked.
So I think those who said that we have to learn to live with the virus are absolutely correct. We're not going to be done with COVID-19 until there's a vaccine that's available, that's effective. And not only that, the vaccine has to be widely distributed around the globe, actually, before we'll be done with this. My thing is that if you're going to reopen the economy, it's unethical, in my opinion, to do so without giving people the means they need to protect themselves. I'm talking about the grocery store workers, those who work in factories or meatpacking plants. You cannot force people to go back to work if you can't protect them from the virus. And to me, it's irresponsible and unethical to do that. And that's what's happening in a lot of places. So I agree that we have to reopen the economy, but I think we should feel obligated to give people what they need to protect themselves. And that's the part that I find disturbing in all this. We can't keep everything closed forever, that's true. But if we're gonna do this, let's do it in a way that allows people to take the steps they need to protect themselves. That would be my contribution to this.
Thank you both.
Thank you, Doctor.
Thank you so much.
I wanna recognize President Heather Wilson as well. President Heather Wilson, you are live now.
Doctor, thank you so much. The one question that I have is for a population of students. The University of Texas at El Paso has 25,000 students. Most of them do not live on campus, so they're coming and going every day. And as we come back in the fall, one of the things we've been trying to figure out is if we choose to do surveillance ourselves, which we actually can do, because we have the research machines to be able to assess the presence of disease. What is the best recommendation for the percentage of the population that we should be surveilling every month or every week in order to block out this disease? I understand the strategy of diagnosing the ill, quarantining them, tracing the contacts, and so forth. But what is there? UC San Diego says it's 60%. Is that the right number?
Yeah, I think, I'll just comment sort of briefly and I'll turn it over to the other expert on the call. I think that you can build a model on how to sample a population with both the frequency of the sampling that you do as well as how you do the sampling. So you want to do the sampling in a way where you're sampling from different potential pools of people who might be in contact with each other. Not everyone's intermingling, so you think of something like a residential college campus. Well, you want to sample every dorm. You want to do a certain amount. You might want to sample a certain number on the floor. I'm quite confident there's statisticians and epidemiologists on your campus there that could put together a model to do that. You don't need to test everyone, but there's going to be tools available to do pooled samples where you can say, if the incidence is relatively low, you can say everyone's going to spit in a cup and we're going to pool that together and test people 100 at a time. And that makes it far more efficient. And then if you get a hit on one of the pools, then you go back and individually screen everyone in that pool. If you're expecting a high incidence of infection, the pools are smaller because you're going to get a lot of hits. If you think the incidence is low, the actual amount of infection in the community is going to be low, then you can make the pools larger. The other thing I would just say is in terms of using the equipment at the university, and this has come up a lot, this question, a lot of universities have equipment that they could use to do this screening. The question is, can you use it on people? I think you're going to see guidance coming out from regulators around this, but my understanding is that the way the construct's going to be, and I'm not sure about this, I'm speculating a little bit, but the construct's going to be is that so long as you do a confirmatory test when you get a hit with your research tool, so you're going to be using your own equipment in a research capacity, but as long as you go out and get a proper diagnostic from a clinical lab to confirm a hit, then you can use positive, then you can use the research tool to do the screening. But that's something that you want to look into as well to make sure it's compliant with all the regulations. I have to say that as a former regulator. So thanks a lot for the question.
I would say that I agree with the other expert that the level of testing you do depends on what you expect the positive rate to be. And the greater it is, the smaller the number of tests need to be done, the smaller, the greater the number. So, and I've been advising the pooled approach where you take samples from multiple individuals and test them, especially if those individuals are going to be groups or cohorts. That makes it easier to do just by doing groups of people rather than trying to test everyone. So that would be my recommendation. I think that's what most universities are going to do.
Thank you. I will be calling on next Mr. David Jerome with the El Paso Chamber. Followed by him, I'll be calling on State Senator Jose Rodriguez as well. Mr. Jerome, you're live.
Yes, I just had to unmute myself. Can you hear me?
Yes.
I think one of the things that we were looking at is that as a phased reopening is sort of inevitable, obviously. What are the indicators that you think we need to look at? It seems like, as we're sort of putting together the playbook for this, we have sort of a gas pedal and a brake going on at the same time. If we do need to slow down, what are the indicators that we should be looking at that we think are reasonable to say, you know what, it's actually time to clamp down a bit. We've opened too fast.
Thank you, David. State Senator Jose Rodriguez, you're live now as well. Senator?
Senator, you may have to unmute.
Unmute. Okay.
Eduardo,
Yes, there he is.
Okay. First of all, thank you, Congresswoman, and our guests for taking the time to share this information that is so important for all communities. And so El Paso welcomes you, even if it is just on video. My question is kind of like what David Jerome was raising, and I think Dr. Gottlieb alluded to earlier in a response to another question. My question is that here in Texas, our governor, Abbott, has started to reopen the economy in phases based on two factors and two factors only. One is the hospitalization rate, and the other one is the percentage of positive test results based on the overall testing. And so my question is, are those two factors the only factors that we should consider? Or are they even valid in terms of being the sole factors that is being considered to continue opening the Texas economy?
I mean, it's a hard question to answer whether they should be the sole factors. And again, I'm not familiar with the decisions that Texas has made. I'll say that other states are looking at hospitalizations as a measure. I know in Maryland, we're doing that as a measure of whether or not there's a resurgence in infection as we slowly reopen parts of the economy in a very staged fashion where there's pauses in between stages, and we're looking at hospitalizations. And that's in part because hospitalizations end up being a harder metric, if you will. The number of new cases is going to go up for sure. I mean, the cases are going to go up as we reopen. There's no question about that. The question is it a manageable level? Do you have in place the tools to mitigate the spread that you're going to see? But you're going to see an increase in spread unless the seasonal effect is very strong. But it's harder to look at the number of new cases in an environment where you're ramping testing rapidly, because you're going to get more cases because you're testing more. And so you want to look at positivity. You want to see the positivity rate coming down. So as you're testing more, you might be capturing more cases, but you're capturing a lower percentage of cases of the total that you're testing. So that should be going down. But hospitalizations, you want to look very closely at that, because a sort of fixed percentage of people will end up getting hospitalized with infection. So it ends up being a more objective measure on whether the epidemic's expanding. Now, that said, there's a delay in time to hospitalization. Typically, it's about 8 days between the time you get infected and the time that you would be hospitalized if you're someone who's going to get a bad infection and end up being hospitalized. And so that's why a lot of states, as they are reopening and looking at hospitalizations as a measure of what the impact of the policy changes that they're doing are having long enough pauses to see that effect. And some states are talking about 2 weeks, waiting 2 weeks, because that gives you enough time to see if there was going to be an increase in hospitalizations. You want to wait a sufficient amount of time to actually be able to detect it. And in fact, when you look around the country, you've seen some states where there's been a slight bump up in hospitalizations in recent days. Probably not enough to draw a firm conclusion, but if you look at the data, and I put this out on Twitter last night, in Georgia, in Florida, in I believe North Carolina, you've seen slight upticks in hospitalizations in recent days. Texas doesn't report hospitalizations, so I'm not able to track it. But in the states that report hospitalizations, and it's about 60% of states, you've seen some states, some reopened states, where there has been a small bump up in hospitalizations for COVID in the last several days. And the other thing I'll say, I'll just pause here. We were seeing a sustained decline nationally in hospitalizations for about 2 weeks. If you look at the data over the last week, and again, I put this out on Twitter last night as well. If you look at the data over the last week, it hasn't gone up, but it's been about flat. And so the declines that we were seeing in hospitalizations over the prior 2 week period has sort of flattened out. And that could be from the impact of the reopening.
I would just add that I think it's important that the percent of positives should be flat or go down as you expand the testing. That would be a really good sign that the mitigation is working. I do agree that hospitalizations are a more rigorous way of looking at what's really happening, because a fixed percentage of those who get the virus will need to be hospitalized. So that makes a lot of sense. But I would also like to see the percent of positives go down as you expand the testing. That would be a really good indication that what we're doing is working.
Thank you, Doctor. I believe we have time for one more question before we have to close for the day. I will be recognizing Emma Schwartz. You are live.
Great. Can you hear me?
Yes.
Yes. Okay. My question is very similar to Dr. Wilson's, but there's very little concrete guidance on employer testing strategies for safe reopening, both upon initial reopening and regularly thereafter. Where can a community go for help in developing a private sector testing strategy that will not bog down the community's sick or potentially sick testing strategy? So in particular, employers may not have access to statisticians to help them come up with good plans. So they're having knee-jerk reactions to say, I need to test 100% of my employees, and thereafter maybe 25% a week or 100% a week. And I think that without providing some sort of structured guidance that can be shared nationally for different types of employers, we're going to have a very disjointed private sector testing strategy that may not be effective. And I have researched and found very little. Where do you suggest we go for that kind of guidance?
Well, look, I'll just say you're exactly right. I mean, I've been talking to a number of employers, executives in a lot of different corporations that want to do testing, and they're all trying to develop their own independent plan. They don't know what technology to use. I mean, you need to make sure that the technology used is fit for purpose. There's different different goals of testing in the employment setting, and so different technologies serve different purposes, and you need to make sure the technology is fit for purpose. And then the question is, how do you sample? What do you test 100% every Friday? Do you do random sampling every day? How do you sample those pools? I'm working on a paper right now to try to address some of these issues. I'm not going to be able to get at the issues of how you design the proper protocol for the setting. But you're right. There's no guidance out there right now. I'm going to be publishing something on this shortly. We're literally working on this right now. really this guidance should be coming out of CDC and hopefully public health departments at the state level that could be more granular than what I'm going to be putting out. I'm going to be addressing it's more at a policy level of how you think about the different technologies and deploy them for different employment-based challenges. But the actual implementation of the protocols, to your point, I haven't seen anything out there that addresses that.
I would just add that one of the great failings in all this, in my opinion, is the failure to have a nationally coordinated response. And this is one of those instances where one of the national agencies should be giving guidance to small businesses and all of us really, and they're not doing it. And so I'm happy to hear that Dr. Gottlieb is doing it. We're part of a group here in Nashville that's doing the same thing for some local businesses. But hopefully there will be some guidance coming online as we learn more about the virus, and there'll be some protocols that people can adapt for their business as appropriate. But that should be coming online here pretty soon. But again, in my opinion, that's one of the the failings of not having a nationally coordinated response to the virus.
Thank you both. So we have a lot of folks who have questions in the queue. What we're going to do is we're going to try to get those questions from our participants, and we'll try to get them answered for everybody. So it may take us a little bit of time, but I want everyone to know that we're going to work to get your questions answered. I do want to ask my own final question, Doctors Hildreth and Gottlieb, if you wouldn't mind. And I know that that you all are not intimately familiar with the state or with the community, but given our vulnerability, given our minority population, given our poverty rate, given our location on the US-Mexico border, what would an ideal testing percentage, testing and tracing standard be? Something that we may not be able to achieve given resources or given availability. But if we were to set a goal, what would that goal be?
Well,
we've got Southern New Mexico testing at 5%. We've got El Paso testing at 2.5%. We've got Ciudad Juarez probably at 0.5%.
Yeah, I almost can't even venture a guess. I would say look at there's some other states that I think are doing a very good job. And I'm not saying your state isn't, I just have less insight into it. There's states I think doing a very good job of getting testing into the community. And I would look at some of those states. Massachusetts is testing a very high percentage of its population. New York is now, Louisiana is. So I would look at some of the states that are testing a high percentage of their overall population and look at what they're doing at a local level at-risk communities and maybe use that as a benchmark. I publish on the AEI website a list of which states are testing the most as a percentage of the population, so testing density. And so I would look at some of the states that are doing a pretty good job in terms of testing density and then see what they're doing at a local level. And recognize that I think it's going to be cheaper and easier to expand testing as time goes on because the tools are going to be there. Just to give you an example, and I'll just end here, but the Sophia 2, which is an antigen-based test, which was just authorized by FDA over the weekend, that's a test that's already used by a lot of doctors to test for strep throat and flu. A box of 100 test strips for that, a box of 25 test strips for that costs about $100. So about $4 a test. And so we're getting testing down to a price point that's going to make it more affordable to really get it out into the community more. So I think the opportunities are going to be there to do wider testing.
So ideally, you'd like the percent of positive tests you get to approach the expected frequency of the virus in the population. So that would mean that if your testing is not yielding a result of 10% positive or less, you're probably not testing enough individuals. So, and for a while there, that was the benchmark, trying to get a percent positive of less than 10%. And if you achieve that, then you kind of feel good that you're testing enough people. That's just one idea to put out there, but clearly the level of testing right now is not sufficient. And given the vulnerability of the population, I believe that testing should be happening on a large scale in your region to identify the positives as quickly as possible and keep others protected from getting infected.
Well, I want to thank you both again so much. We promised that we'd just keep you for an hour, and we're going to keep that promise. I want to thank everybody on the call. I want to thank everybody watching on Facebook. This is an effort to really help us chart out our own path. And the folks at the Office of Emergency Management are doing a fantastic job with the resources that they have. But I think to the point that Representative Blanco made at the very top of the call with our first question, we really do have to look at our community with a regional perspective. As I just mentioned, Doña County, 5% testing, El Paso 2.5%, and El Paso's done a great job of really ramping up over the last week and a half, now testing asymptomatic folks. Ciudad Juarez, really just incredibly deficient in terms of its testing strategy. We haven't even really talked about tracing on this call. We haven't talked about screening in great depth. Dr. Gottlieb mentioned it. That's something we've really got to start thinking about as well, especially if we want to continue to ensure that our community and region remain safe. My hope is that as a region, we lay out an international tri-state strategy. We share the same air, we share families. We are a fluid place, which is wonderful, but with that comes some challenges, and especially during a time of pandemic. So looking forward to working with all of you on that kind of broader strategy, identifying those benchmarks that we need to set for both screening, testing and tracing, so that we can do a better job, not just of dealing with a crisis, but thinking about prevention, especially as we come out of the summer and as things really become opened up far more broadly in earnest. So with that, thank you so much, Dr. Hildreth, Dr. Gottlieb, and thanks to the great community that we are all so lucky to live in. You all stay safe and take care of yourselves.
Thank you.
Thank you.
Okay, we have ended the session.
Judge,
You have to unmute yourself, Judge. You're still muted? Oh, you muted.
Cesar, I was saying that we need to close the meeting.
We can go ahead and adjourn if you like, Judge.
Yes, I would like to do that.
Okay. This concludes today's meeting at 11:05 a.m. Thank you all.
Thank you. Meeting adjourned. Thank you, and have a safe day and week. Thank you.